So thank you very much, Catherine, for giving a fantastic overview of many of the issues that we're going to be talking about in the rest of today's session. So I'm Mitzy Gafos, I'm a co-research director of Strive, and I'm going to give you a bit of an overview of the work of Strive. As you've heard from Saidi, over the last 7 years, Strive have been funded by DFID to tackle the structural drivers of HIV. The Strive proposal was developed in the context of acknowledging that 30 years into the epidemic, and despite sustained progress, the number of newly infected individuals outstripped those who were accessing treatment. At that time, there was great optimism about behavioural and biomedical interventions. We had established evidence around male medical circumcision. There was breaking evidence around the benefits of the effective treatment in preventing onward transmission and on oral pre-exposure prophylaxis, and real excitement about the possibility of vaginal microbicides. However, there was initially limited but certainly growing recognition that structural drivers not only exacerbated the risk of HIV, but also inhibited the uptake of biomedical and behavioural prevention options, including options such as PrEP and effective antiretroviral treatment. So while there were increasing calls for the need for structural interventions to address the drivers and to integrate structural interventions into combination programmes, there was limited evidence of the best ways to go about doing that. And it was in this context that Strive started much of its work. So the overarching aim of Strive was to provide evidence on the best ways to understand and tackle the key structural drivers of HIV risk and vulnerability and enhance and impact on proven HIV prevention strategies. As Saidi has explained, the aim of today is to present a synthesis of some of our work in order to generate a debate about the role of structural interventions in the context of responding to the SDGs and implementing combination HIV prevention programmes. As such, we wanted to avoid bombarding you with 7 years of evidence of what we have produced, but we do want to try to give you an overview of the work that we've done, and so to be able to familiarise you with our work and to help you navigate through the resources that we've been able to produce so as you can hopefully benefit from them going forward. You'll have all received a memory stick on your arrival, and on there are many of the resources that I'm going to be giving you an overview of today. I'm going to highlight to you the items that are provided on here, but all of them are also available on our website. So for the rest of the talk, I'll describe the types of evidence that Strive have produced in response to these sort of 10 overarching aims. So I'm going to talk you through the evidence that we've produced and some of our thinking around how we have identified key structural drivers that are amenable to change within programmatic timeframes, how we've aimed to enhance our understanding, and how we have conceptualised some of the structural drivers that had not been well defined, how we've described the pathways through which drivers influence the risk of HIV, how we've aimed to improve the tools used to measure structural drivers, how we've designed and evaluated promising structural and combination interventions, how we've conducted other research to further explore the impact of structural drivers on risk and uptake of services, some of the synthesis work of existing evidence that we've combined with the new evidence of Strive in order to produce technical briefs on a range of different drivers, some of the support that we've aimed to transfer knowledge into action by ensuring our evidence is available to as wide an audience as possible, some of the aims to monitor and measure the uptake of our evidence and the impact of our work, and last but certainly not least, the aim to strengthen capacity to respond to structural drivers and expand on the resources that are available. So, for the first aim, in recognising that there were a vast number of structural factors that influence HIV, we aim to identify the key factors that were amenable to change within programmatic timeframes. We started with a conceptual framework to identify the macro level, political, economic and social structural factors that in turn influence the community level structural factors such as gender inequality and many of the issues that Catherine raised, that in turn influence interpersonal and individual level risk behaviours such as transactional sex, which again influence the proximal determinants of risk such as individuals having sex without a condom and impacting on HIV transmission. In mapping out the conceptual framework, we recognised that while we could intervene at the macro or community level, factors at the community level were in reality more amenable to intervention and evaluation within the timeframes that we were aiming for. So as such, we've identified a set of structural level drivers to focus our attention on. And we formed working groups led by co-chairs across consortium partners to focus on these specific set of drivers, which has included alcohol availability, promotion and drinking norms, to explore the associations between risk factors and harmful alcohol use, sexual risk behaviours and HIV risk among young people. Stigma and discrimination, to explore the impact on the uptake of treatment and prevention services and the impact of expanded treatment programmes on the manifestation of stigma. Gender norms, inequalities and violence, to understand the pathways linking harmful gender norms and resulting inequalities and violence, and to design and evaluate interventions to shift norms to both improve adolescent girls' access to education and reduce intimate partner violence. In addition, we identified other topics for further exploration, which included transactional sex, to assess the importance of transactional sex as an interpersonal level factor for HIV among young women in sub-Saharan Africa and map the pathways of associations with upstream structural drivers. We also established a co-financing working group to develop economic evidence for the benefits of intervening upstream and identifying funding opportunities for co-financing. Finally, we identified three overarching themes to focus on, what we've called meta-narratives, which isn't the most helpful term, but it's how they're termed on your USB stick, so as you know what we're referring to. And all of the evidence from our thematic work really feeds into these meta-narratives, and this is going to be the focus of today's presentation. Firstly, looking at the thinking around development synergies to assess the potential for structural interventions to impact on multiple development priorities within the context of the SDG agenda. And secondly, biomedical interventions to assess the impact of different structural factors on the uptake and adherence to biomedical prevention options and HIV treatment and the implications for interventions. Our third theme around adolescence will feed into both of those talks today, and that very much focuses on the aim to identify and synthesize evidence of interventions that successfully address the structural drivers of HIV for adolescents and young women. So this graphic really presents an overview of how we've organised our work and how you will be able to find and access some of our products. So in terms of the second aim, to enhance our understanding of structural drivers that were not previously well defined and provide a conceptual framework within which to measure them. One such example is our work around norms, which has resulted in reports on measuring and defining social norms and harmful gender-related practices, and which supported the development of a number of interventions to shift social norms around gender inequality, girls' education, and intimate partner violence. A second example is the conceptual work around transactional sex, and Catherine has already highlighted the report that has been launched today. For many years, transactional sex has been conflated with sex work, which has been counterproductive as interventions designed for sex workers have then not gone on to reach the people engaged in transactional sex. So based on a substantial systematic review of the evidence that was available and with additional quantitative and qualitative work, the STRIVE working group developed a definition of transactional sex as a non-marital, non-commercial sexual relationship motivated by an implicit assumption that sex will be exchanged for material support or other benefits. understanding the interrelated motivations for transactional sex, which includes sex for basic needs, sex for improved social status, and sex and material expressions of love, is critical in order to design interventions that are able to address the economic vulnerabilities and gender inequalities that exacerbate the risk of young women engaged in transactional sexual relationships. So our third aim was around describing the pathways through which more well-defined drivers influence the risk of HIV and the uptake of services. So mapping the causal pathways of interest is key in terms of being able to design structural interventions that alter the mechanisms through which upstream drivers of HIV influence the proximal risk behaviours within specific contexts and within specific populations. This has included a substantial amount of work on intimate partner violence as the most prevalent form of gender-based violence. And Strive have convened an expert group to map not only the structural but also the behavioural and biological pathways that link intimate partner violence and HIV. And this expert group meeting resulted in the Green Tree report, which synthesises both the evidence and the thinking around these interrelated multiple pathways. Some of this work has also resulted in a report on the evaluation of what works to prevent intimate partner violence. So the fourth aim is very much around improving the tools that we use to measure structural drivers. And this is necessary in terms of both estimating the prevalence of specific drivers across studies consistently and being able to compare, and also to enhance our understanding of the pathways of association and to accurately assess the impact of interventions. So we've produced measurement briefs on alcohol-related HIV risk, intimate partner violence, social norms, HIV stigma and discrimination, and transactional sex and HIV. So on the USB stick, you have a list like this of over 75 Strive journal publications, which I am obviously not going to go through in any way. Instead, what I'm going to do in the next couple of slides is highlight the products that we've produced to support the uptake of our findings based on the scientific evidence that we've collated. So the fifth aim really of the Strive partners was based on available evidence to design and evaluate the most promising structural and combination interventions. So we've evaluated 5 interventions in total and produced evidence briefs on the Samata trial, which aimed to increase secondary school completion and reduce child marriage among marginalised young girls in southern India, and you'll hear a little bit more about that in some of the presentations today. The Maisha trial, which aimed to provide empowerment training to reduce the risk of intimate partner violence among women in Tanzania. And again, you will hear a little bit more about that, although their results are still embargoed until later this week. And we have forthcoming evidence briefs on the Parivartan trial, which was a sports-based programme aimed to enhance developing skills and shifting norms among adolescent girls in northern India. The Samvedna Plus trial, which was an intervention designed to reduce intimate partner violence among some of the most marginalised sex workers in southern India, and Empower, which is a combination prevention programme that assessed the feasibility of screening for gender-based violence in HIV prevention programmes and supporting PrEP uptake and adherence among adolescent girls in South Africa and Tanzania. And again, you'll hear a bit more about that. So under our aim 6 to conduct a range of other research, this included a mixed method study on alcohol availability and marketing using a geographic positioning system to map the proximity of alcohol outlets to schools. And it also used an innovative participatory practice method called Photo Voice to engage young people in South Africa, Tanzania and India to use photography to document their experiences of alcohol and to then use those photographs as the basis for discussions in focus group discussions. We've produced 2 evidence briefs from this work in South Africa and Tanzania. We've also implemented a stigma sub-study within the large POPAR Universal Test and Treat intervention, conducted qualitative research around transactional sex and economic costing evaluations in the Swateka HIV prevention trial for young women in South Africa, and contributed to the SASA community mobilisation trial in Uganda, looking at reducing intimate partner violence. Now, in addition to summarising our own findings, we've aimed to synthesise the full body of evidence on these topics, which has been built around systematic literature reviews, meta-analyses and secondary data analyses of the available data. In addition to adding to that new evidence generated by Strive. And we've pulled all of that together on key topics to be able to provide technical briefs so as people have got an easy go-to document to help summarise the evidence and the current thinking. And so far we've produced 5 of these thematic technical briefs on alcohol, stigma, social norms, transactional sex and co-financing, and there's another one in preparation on intimate partner violence. And we've also produced overarching technical briefs on the potential for development synergies and the biomedical prevention cascades, both of which form the basis of today's presentations. We're in the process of preparing a technical brief on the adolescent interventions, which does include a systematic review of the effectiveness of structural interventions and the impact that those interventions had across multiple structural, behavioural and clinical outcomes. So, as I said, a key focus for us has been making sure that our evidence doesn't sit in academic journals, but that it is available to as broad an audience as possible. And in that, we have aimed to support the transfer of knowledge into action. We've developed a series of graphic and film-based infographics on a range of different topics. And in this afternoon session, you will see the launch of the new HIV prevention cascade infographic. We also hold monthly learning labs that you can sign up to, where individuals present their slides and give a talk on these specific topics, and all of these are available online for you to see at any time you wish. So, Aim 9 in our list that we started with was to try to monitor and measure the uptake of our evidence, and most importantly to actually report on the impact of our work. And this has led to a series of impact case studies at a national level on the impact of our research on the national alcohol policy in Tanzania and in South Africa, the influence of our work on policy and training around stigma in a range of settings in India, and the contribution of our work to the prioritisation of the need for combination HIV prevention for adolescent girls and young women in South Africa. In addition, we've produced 3 impact case studies on global impacts in terms of the inclusion of validated questions on stigma in the Demographic Health Survey and via the Global AIDS Monitoring process, inclusion of questions on transactional sex, again in the DHS, and the inclusion of the co-financing approach in the South Africa HIV and TB investment case to the Global Fund, and implementation pilots in 7 countries with UNDP, which you'll hear more about in this morning's panel discussion. So our final aim was to strengthen the capacity across not only our partners, but also the global and local stakeholders in order to support people to enhance their ability to respond to the structural drivers and expand the resource base and availability of those resources. And that's very much part of the aim today, to highlight what is available for people to draw on. All of our resources are available on our website, as well as on your stick. And just in summary, so over the last 7 years, Strive have enhanced our understanding of the structural drivers in terms of identifying those that are amenable to change, enhancing the conceptualization and evidence base of the causal pathways, and improving measurement tools. We've evaluated structural and combination interventions with varying levels of success and conducted other relevant research. We've also produced a range of resources to support the transfer of knowledge into action and enhance capacity to tackle the structural drivers of HIV. We hope that today's session will really offer an engaging opportunity to discuss the implications of our broader overarching learnings that have come from this vast body of research. So our aim for the rest of the day is really to synthesize overviews of two of our key topics. So we didn't want to go into all of the detail of this, but to help you navigate through the resources that we've got.